Good morning. Welcome. Nice having you. Welcome to the Jindal School of Management. This is our annual fall healthcare leadership conference. We try and hold a conference this time each year with a topic that is of interest to the business community as well as the general community. It's very nice to have all of you here today. This is under the auspices of the Center for Healthcare Leadership and Management here in the Jindal School. We have 6 different degree programs in healthcare management administration that we offer here at Jindal. For those of you who might wish to advance your career educationally in terms of a master's degree in that area, you can look on our website and see that there are numerous programs available, one of which might accommodate your particular needs for it. Before we start, I'd like to say a thank you to Quincy Sineley and Rhea Woodcock and the administrators from our Healthcare Management Association. They're the ones that you see around here, and they're the ones who basically have done all the heavy lifting for this program today. At the end of the presentation of our panels today, we will open up to a question and answer for the audience here. Our ambassadors will have handheld mics, and we'll bring those around so you can ask your questions at the end of the presentation. It's very nice to have all of you here. I'd like to introduce our panelists who will be doing our presentations today. The first one is Dr. Paul Convery. Paul is a clinical professor on our faculty here. Prior to joining our faculty several years ago, he was the medical director at Baylor. Many of you know Mr. Steve Love. Steve is the president and CEO of the Dallas-Fort Worth Hospital Council. The Hospital Council represents 90 hospital organizations and another 90 associate organizations in the Dallas-Fort Worth area. Steve's very well known to this community. And then Mr. David Toomey, who's the senior vice president at ShareCare. David is an authority and an expert with a long history in the healthcare insurance arena. So I think you'll find those presentations very interesting today. As a start, we have a healthcare system that is not economically sustainable. Starting all the way back in the late 60s or certainly in the early 1970s, for every decade, the rising healthcare costs have far exceeded inflationary cycle costs. And that's a trend that is still continuing today, and over those decades, we have never succeeded on a long-term basis in containing those healthcare costs. And certainly, those of you, the businessmen and businesswomen in the world here, are certainly well aware of those factors as they escalate every year as you fight the battle to try and contain the healthcare costs for your employees. What I'm going to do as a very brief introduction for you is simply show you that in a little bit of a perspective that you may not have seen that will explain what the problem is and why are we in a situation now where people are talking about some radical transitions and some radical changes in the healthcare system, including the idea of Medicare for all. The projections of such in terms of escalation of national health expenditures continue to go up and up and up, as they have been doing since the 1970s. If you want to look at it as a percentage of our GDP, it shows that picture. Another way that you can look at it is from the standpoint of per capita expenditures. Whatever criteria you want to use, the trend line is markedly upward all the time. If you want to compare us to other well-developed countries, you see that the United States is a marked outlier. In essence, overall, we spend about twice as much on our health care, if you look at it in terms of GDP or per capita. We spend about twice as much for our health care as other well-developed countries do. But what do we get for that expenditure? Well, unfortunately, in terms of overall quality, the United States ranks very poorly. Now, granted, the best of the best of the best of healthcare in the world is here in the United States. If you're really sick, this is where you ought to be for your care. But unfortunately, that overall quality care is not extended to our entire population. And so we rank very poorly in overall care compared to these other countries, despite spending twice as much as anybody else. Medicare, as a share of the federal budget, it's big, it's getting bigger, and will continue to grow and escalate in the future. The financing mechanism for Medicare, particularly for what we call original Medicare, that's Medicare Part A and Part B, was established at the time of the passage of Medicare in 1965. And that's not going to work for the future. The projected Medicare spending, again, same picture. Upward trajectory. Now, Medicare funding. Medicare has four parts. The original Medicare, Part A and Part B. Part A is funded through a designated payroll tax. Part B is partially funded through premiums, but that's only about 25% of the overall expenditures. The other 75% comes from general revenue funding. And the same is true of Part D, which is the pharmacy drug component. Again, 25% of that is funded through premiums, but the other 75% comes from general payroll. And Medicare Part C is a managed care type program. It's optional, but surprisingly enough, about 32 to 33% of all Medicare recipients here in the United States today have elected voluntarily to accept Medicare Part C, which basically is A, B, and D all combined together in narrow networks in either an HMO or a PPO organization. Here's part of the future problem in terms of the financing for Medicare. This sharp increase that you see here that started in 2011, that's the baby boom generation. The baby boomers, about 77 million strong, started entering January the 1st, 2011, and 10,000 new baby boomers a day are entering Medicare. 10,000 a day. And that's that sharp increase in the line that you see there. But in terms of the future financing for it, here's a major problem. Particularly, we're talking now about Medicare Part A. This is the payroll tax, which is allegedly being put away in a trust fund for future use. Well, that's not true. Actually, the money that's in the trust fund is being steadily depleted. And in the future, the total number of workers who are contributing into that trust fund, that is, that payroll tax that is automatically deducted from your paycheck, the total number of workers, which is about 4 workers per 1 Medicare recipient today, is going to decline down to about 2.5 workers for every Medicare recipient. And the net result of that is that the Medicare Part A trust fund is estimated that it will be totally depleted by approximately 2026. So the financing mechanism of it is not going to work for the future. This is the latest, newest study that in a survey that came from the Kaiser Foundation. This has been receiving a lot of attention in the media over the last couple of weeks when this came out. And the shocking thing about it is that the overall premium cost for a family premium now is now in excess of $20,000. You can go back to 1999 when that cost was $5,700. But now Insuring a family with a policy, the overall average cost now exceeds $20,000. Here is a key factor in terms of how this affects the public in general. These 4 lines basically tell a grim story. It covers the period from 2009 to 2019, so a 10-year period of time. The bottommost line is inflation. And inflation has certainly been under control over that period of time. And over that 10-year period of time, inflation was about 20%. The line just above it, the 26%, represents workers' wages. Essentially what it says is that over this 10-year period of time, and incidentally, you can extrapolate this line and this chart all the way back to the 1960s or 70s, and you see the same kind of trend. This second line, workers' wages, essentially are saying that the increase in workers' wages are barely keeping up with inflation. So in terms of take-home money every year, the workers, for the most part, are not seeing any kind of significant increase. Why are they not seeing an increase? Well, that's because of line number 3. Line number 3 is the escalation from the standpoint of healthcare premiums. So the differentiation between line number 2, workers' wages, and the orange line that you see on the slide here, the premiums, is money that otherwise would be assigned to workers' wages, the increases. But those of you in the business community are well aware that with this kind of healthcare premium increase, you can't afford to do that. But that's not the final factor. The final factor is the top line, the yellow line, because that line represents deductibles. This is out-of-pocket money for your employees. So they not only are not getting significant wage increases because you as employers cannot afford to give them that, but now out-of-pocket expenses to the employees have risen markedly. In this case, over that 10-year period of time, 162%. And concomitant with that has been a steady increase in terms of the deductible. The latest study from Kaiser has come out, and the average deductible today is now $1,600. So many of these deductibles are on an upward trajectory. In the next year or so, that average is probably going to be closer to $2,000, and that's out-of-pocket money for the employees. Those are the economic factors that are driving the fact that changes in our healthcare system economically are absolutely necessary. Basically, the family premium as a percentage of the median family income, the median family income in the United States today is about $56,000. Premium costs are approximately a quarter of the median family income. That is not an economically sustainable situation. And then this final statement, I wanted to show you, this is the income statement of the United States. These pie charts are on scale, and you will notice that the smaller chart on the left-hand side represents the revenue, all income for the country. The larger chart on the right-hand side represents our expenditures. And when you look at that, not only do you notice that it's larger, but if you will notice certain segments of it, the total interest, Social Security, health care, welfare, those are entitlement programs. If you add all of those up, essentially what you come out with is that the entitlement programs, including payment on our interest, which is required by law, basically equal the total revenue of the United States. So if you are concerned about the fact that we are running deficits and that our debt is getting bigger and bigger and bigger all the time, what it says to you is that the only way that we are ultimately going to gain control of that future problem, because all of the other things shown on this right-hand pie chart, infrastructure, defense, and everything else, basically is being paid for with borrowed money. What it says is that basically, in order to gain control of our future deficits, it is going to require alteration in the entitlement programs. And to a great extent, that is Medicare and Medicaid. So, ladies and gentlemen, that's the financial background, the situation that we are in today. And as a result of these factors, as you are all well aware, the discussion of a marked change in our healthcare system under the umbrella word of Medicare for All is right on the front burner. This is going to be hugely discussed in the upcoming primaries and be a major, major discussion factor and platform item in the 2020 presidential election. So that's the world as it exists today economically, and that's why the discussion of Medicare for All is very, very germane to what's being done. The title Medicare for All is a broad-based umbrella. There are multiple factors involved in that, and Dr. Convery is going to tell us what they are. Thank you.
Thank you, Dr. Fleming. Good morning. So I'm Paul Convery. I'm a clinical professor of healthcare leadership and management out here. I've spent my entire career in healthcare and have touched virtually every aspect of it, from practicing physician to running large medical groups, to being a hospital president, to be a senior executive in a couple large health systems, and even ran a small insurance company at one point. So it's not surprising for me that Medicare for All, or a discussion of the National Health Insurance Program, is on the agenda this election cycle. But what is surprising is that it's a major topic, and for the first time in 50 years, it has broad support and majority support across the American public. Medicare for All was first promoted as a public policy topic in 1970, and it was advanced by Senator Jacob Javits, a Republican senator from New York. And the concept of a national health insurance program has been on the election cycle since the days of Harry Truman, and has come up more or less pretty much every cycle, but hasn't gotten a lot of national attention or national traction. Mainly because the public were very comfortable with the status quo. They felt that their employee-based commercial insurance was a pretty good system and was taking care of them okay, and they didn't see a big need to change. What has happened, and just as a side, all the graphics are from various surveys. The source of the survey is mentioned on the graphic, and the dates are all relatively recent, some as recent as a month ago. What has changed is that cost of health care, as Dr. Fleming pointed out, has become an unsustainable burden to the American public. This has been most acute over the past decade, and the average voter has reached their breaking point. For Americans with commercial insurance, this is employee-based commercial insurance, and that's about 160 million people. If you throw in the people with individual plans, it's 180 million people, so that's the majority of Americans. Over a third of those with serious medical conditions have said they've used up all their savings to pay for health care. 70% of Americans say that they are cutting back on food, clothing, or other basics to pay their health care bills. And 30% of Americans with insurance, with good commercial employer-based insurance, say they cannot afford health care if they got sick. The World Health Organization has said recently that the American millennials will spend between 50% and 70% of their lifetime earnings on health care. That's an unsustainable number. So what has happened is you now have 60% of Americans supporting the concept of a single-payer system. And this has grown dramatically over the last 40 years. And if you go back to the 1950s, it's just really a dramatic increase. But it follows that massive increase in cost of health care that Dr. Fleming shows you on the previous slides. The out-of-pocket cost of health care, surprise, unexpected medical bills, escalating drug costs, higher deductibles, and co-payments have hit them in the pocketbook, and Americans vote their pocketbook. The promise of the current healthcare system, as it's been set up for the last 50 years, solving their problems, that promise has been broken for many of the average Americans. Now let's look at the Medicare for All proposals. There's about 10 or 11 different bills filed in this Congress under the rubric of Medicare for All. I've broken them into categories to make them a little bit easier to understand, and if you have this slide, you can maybe follow the debate over the next year and a half a little bit easier. All the bills have been submitted. Some have had limited hearings, but most of them haven't even gotten to the committee section, and they're not going to be passed this congressional cycle, that's for sure. The first one is a single national health insurance program for all United States residents. That's sponsored by Senator Sanders and Representative Paul, and it has multiple co-sponsors. It's a national health plan, replaces all government health care insurance, including Medicare and Medicaid, and replaces all private insurance. There's no premiums or cost sharing. It's paid for by various taxes, progressive income tax, employer tax, inheritance tax, capital gains tax, wealth tax, etc. Coverage extends to dental, vision, nursing home, long-term care, pharmacy, etc. And there's a national budget and a fee schedule for hospitals, physicians, and pharmacies. The second grouping there is a new public plan option based on Medicare, and it will be offered within the Affordable Care Act marketplace, sponsored by Senator Bennett, Kane, and Delgado, called Medicare X. It's a public option plan on the exchanges. There are premiums that will be paid and co-pays. There will be subsidies for less than 400% of the federal poverty level. HHS sets a premium and negotiates rates and pharmacy costs and rates for hospitals and physicians. Second bill in this category, sponsored Senator Cardin, is Keeping Health Insurance Affordable Act, is a public option plan with cost sharing and co-pays. HHS again sets a premium, subsidies are available as before, and it negotiates rates for hospitals, physicians, and pharmacies. The third big grouping there is a Medicare buy-in option for older individuals not yet on Medicare. It's sponsored by Senator Stabenow and Representative Higgins. It's a Medicare buy-in plan for people between age 50 and 64. Again, there's individual premiums with subsidies. Medicare Advantage option, which Dr. Fleming mentioned, that's the Medicare Part C, the private insurance company option. HHS negotiates and sets rates, including pharmacy, managed by Medicare with a separate trust fund. The fourth is a Medicare for America Act of 2019, sponsored by Representative DeLauro. All United States residents would be covered under a public option, so everybody's covered by a public option unless they opt out for a qualified health plan offered by the employer. So it would eliminate all individual insurance plans, but would keep the employee-based group insurance. There's an option for Medicare Advantage, would eliminate private insurance on the individual market, federal subsidies for premium as before, premium limits 8% of income, and HHS sets reimbursement rates. And the last is a Medicaid buy-in option that states can offer through the ACA marketplace, sponsored by Senator Schatz and Representative Lujan in the House. States can offer a Medicaid buy-in on the marketplace with individual premiums or subsidies as before, managed by the states or Medicaid managed care organizations. Now, except for the first of these, the single national health insurance program, the rest are all a version of Medicare option. They would all preserve the private insurance market in some fashion. Some would maybe even work through it with Medicare Advantage. They would work with the Affordable Care Act and the exchanges. They would all set a negotiated fee schedule for hospitals, pharmacies, and providers, although not necessarily at the current Medicare rates. Now, this negotiated fee schedule approach is what every other developed country uses, and that would go a long way to hold down overall healthcare costs. Most experts agree that the main driver of the escalating healthcare costs are healthcare prices and charges, not utilization. Actually, the data shows American healthcare utilization is below that of every other developed country. Now, there's a lot of room in Medicare rates. The American Hospital Association tells us that Medicare only covers 87% of hospital charges. A recent RAND analysis on transparency of hospital insurance charges show that Medicare charges, that commercial prices paid by insurance companies to hospitals and health systems ranges from 240% of Medicare to 1,000% of Medicare. So if the reciprocal, if you take the American Hospital Association number of 87%, 115% would cover hospital charges. So there's a lot of range between 115% of Medicare and 1,000% of Medicare to find a price that might be negotiated. But that's not available now, so we don't negotiate pharmacy, or we do negotiate them in the insurance market, but as the RAND study has shown, has not been terribly effective to date. And these all provide some type of subsidies or tax credits for those at or near the federal poverty level, and they all would be separate from the Medicare Trust Fund, so they would not theoretically impact the Medicare Trust Fund. Now, multiple polls over the last couple of years show that healthcare is clearly the #1 issue on voters' minds. And this has been repeated in multiple surveys. Some of the numbers vary some, but healthcare and healthcare costs are the major issue. If you look at it from the two partisan sides, you see a slightly different perspective. The Democrats tend to favor congressional action on making sure that all Americans have health insurance, although a significant number are concerned about costs also. There's still 28 million Americans without health care insurance. Republicans favor congressional action on lowering the amount that they pay for health care, but both sides agree that something must be done. If you look at the comparison of Medicare for All proposal with public option in these surveys, you see some interesting contrasts. On your left is the Medicare for All survey. It's favored by 52% of all polled, 77% favorable among Democrats. You see, I'm talking about strongly favor and the somewhat favor colors. 53% favorable among independents, and 19% favorable among Republicans. If you look on the right, you see the Medicare option survey. It's favored by 69% of those polled, 87% favorable among Democrats, 72% favorable among independents, and 41% favorable among Republicans. Now, language and words obviously make a difference in how people react to these various proposals. And as you can see from this, if you call this Medicare for All, the response is generally favorable. If you call it socialized medicine, you get a big negative response. And you're going to see this reflected in speeches and sound bites over the next year and a half. Now, let's talk about cost. As Dr. Fleming has shown you, the national health care cost for health care is almost $4 trillion a year. The range of estimates for the Medicare for All, that's the Senator Sanders plan, and that's what we're going to talk about, not the options. The Senator Sanders plan goes from an increase of 17% above current status quo to a decrease of 10%. This is from the RAND analysis, which is kind of in the middle and shows an increase of about 2%. Now, in the status quo bar at the top, now this is taken from CMS data. That's the National Health Expenditure estimates from CMS, so it's government data. The federal government pays about a little over $1 trillion for healthcare. All told, government agencies pay almost $2 trillion for healthcare. Now, that's federal government, state governments, Medicaid, all the different services coming out of the states and the feds, cities and counties paying health insurance and everything in, the tax deductibles and deductions and everything else. The federal government pays about $1 trillion. All other governments all in pay about half of this cost. The public pays the other $2 trillion, the yellow bar is paid for by the public. That's pretty evenly split between the employers that pay about $1 trillion for health insurance premiums and the public that pays about $1 trillion out of pocket. Now that's co-pays, deductibles, and everything else that the public pays for. We're all paying for this $4 trillion already. It's just whether we pay for it in taxes or pay for it out of pockets or pay for it with insurance premiums paid by employers, which is in lieu of increase in wages. And you also have to add on top of that, there's a $280 billion tax benefit to employers for these premiums. So there's a tax benefit baked into this to the employers that's not usually talked about. So we all pay for this one way or another. The bottom line is that Medicare, for all, the RAND estimate, has the federal government paying the bulk of this $3.5 trillion and the public paying a small amount out of pocket. Now that would imply that you'd have to raise taxes to pay for that. Now, raising taxes to this level is not a trivial event. The voting public has not been very favorable to presidents or to political parties that raise taxes to this extent. So I realize that's not a trivial event at all. So what's driving this? The drivers for Medicare for All, and most of these Dr. Fleming has already mentioned, the cost of PPO health insurance all in, this is co-pays, deductibles, and everything else added on top of the premiums, is $28,000 for a family of four. That's according to Milliman. The median income is about $60,000, so families cannot sustain health care without a subsidy. Percent of Americans who think high-quality health insurance should be the top priority, 68%. Employers pay, again, more than 240% more than Medicare for the same services. Trust in American health care has dropped precipitously since 1977. 71% of respondents think the American health care system is a state of crisis, and the percent of Americans who remain uninsured is 28 million. So what are the drivers against this? Why don't we do it? Well, here's the reality. The American health insurance industry is a $600 billion enterprise. United Healthcare, Aetna, and Anthem alone employ over 364,000 people. The hospital profit margins, we hear, would decline to a negative 9%, with a loss of $86 billion to hospitals and several million jobs lost. And in most communities, hospitals are the largest employer. So this has a real economic impact across middle America. The biopharmaceutical industry is a $1.3 trillion enterprise with over 4 million jobs. And the big line there is healthcare stakeholders in 2016 spent over $500 million lobbying Congress. You can be assured they'll spend much more than that in 2019 and 2020, and that does not include the direct contributions to political candidates, to PACs, direct advertising, et cetera. So there's major financial forces resisting this. Plus, Americans oppose giving the government too much control over health care. We're still kind of squeamish over the government. 61% oppose that in a recent Kaiser survey. And 60% of Americans oppose eliminating the role of employers in health care. We have this concept of, we don't like it, but don't take it away from us. And that's a tough hurdle. And the percent of Americans who oppose a tax increase to pay for Medicare for all is 66%. Against raising taxes is a big political struggle. So what's going to happen? Well, here's what's going to happen. I don't know. But here's what you ought to watch for. One, voters are positive about Medicare, and they're open to options to expand it. Actually, the public that has Medicare likes Medicare better than the public that has commercial insurance. And however, Medicare, they're not positive about more taxes to cover it. And Medicare for all is not achievable with a split Congress and administration. That's pretty obvious. If employers have health insurance, they like it, but not their insurance companies. The 2018 midterm elections told us the health care cost is an issue, especially the cost of health insurance and drugs. So that's a major issue for the voters. Pre-existing condition clauses is important. We learned that from the 2018 elections. So pay attention to the federal case, the case from going through the federal courts now to repeal the Affordable Care Act, which is being advocated for by the administration, because that could have major impact if pre-existing conditions and other benefits that most commercial insurance patients have now, and to think that we're going to have a congressional solution to that before the next election is pretty unrealistic if that gets repealed. And then the elections, midterms told us that they're open to Medicaid expansion. 3 states by referendum and 2 states by electing governors who were supporting it. There are options on the table to fix the Affordable Care Act and incorporate a Medicare option, including Medicare Advantage. That almost sounds like a bipartisan solution if we had lived in a bipartisan world. And then finally, what will CMS, Congress, the providers, and insurance companies do to lower healthcare costs? And they all are working on initiatives, and they're all advocating lowering healthcare costs, but the proof will be whether any of this is carried out and is successful. And finally, polls tell us that 49% of respondents said they've heard little or nothing about Medicare for all, and 64% have heard little or nothing about a public option for Medicare. So the vast amount of people that will be voting for this will be voting for something based on emotions and sound bites and gut feelings and not about real detailed information. And as you can see, this is pretty detailed to get through to the average American voter. So that's where we stand now, and we'll stay tuned. With that, I'm going to turn the microphone to Stephen Love.
First, let me just say it's a real privilege to be here today. I really enjoy coming to these presentations. Forney always does a great job, and he always hits some of the hot topics and things we need to deal with. I always give a disclaimer. As you know, I represent hospitals, and my disclaimer is very simple. What I'm going to say is not tilted one way or the other politically. Believe it or not, we treat Democrats and Republicans and hospitals. So even though you have to peel back the onion and look at politics and how it impacts this, I'm not really saying Democrats are right or wrong or Republicans are right or wrong. But I will say this. Medicare for All, to me, is a cry for help. And you may go, why is it a cry for help? Medicare for All, if you really boil it down, is people, and you've already heard from Dr. Fleming and Dr. Convery, the cost of health care is problematic, coverage is problematic, and you can call it anything you want, but it's a cry for help for people who are looking at the high cost of health care and the fact that they need coverage so that all Americans can get the health care they need. You know, you've heard a lot today, and I want to elaborate on the single-payer system. You know, it's amazing to me, though. I was in Washington 2 weeks ago, and I met with some congressional leaders. I won't name them, but it was one who had put forth the pure Medicare for All single-payer system. And I said, so how is this going to work? Does that mean hospitals become institutions of the government? Does this mean doctors now become government employees? Well, you know, I hadn't really thought about that. That was the answer I got. And I asked a lot more detailed questions and was, well, we really hadn't thought about that, but we need a single-payer system. A word of caution. We're all moving down this road of Medicare for All, and I'm not sure it's really been looked at from a cost point of view and what all the ramifications are. You know, you heard Dr. Convery talk about some that want to add it to the ACA marketplace. And I'm not suggesting that's a bad idea. We need to really support the marketplace. You have the buy-ins. Everything from a hospital point of view and from the American hospital point of view is this is certainly the right goal, and the right goal is to lower healthcare costs and give coverage to people and access. But I'm not sure we're going down the right path. Here are some of the consequences if you did a Medicare for all. You've got 180 million people in this country that currently have health insurance through their employer. If you went to a pure Medicare for all, you would immediately displace those people. Funding would then become political. Again, I'm not going to get into Republicans versus Democrats, but Republicans, for the most part, oppose Medicare for all, and they want health care delivered from the state point of view, not the federal point of view. Democrats, on the other hand, want it to be more nationalized and therefore a single-payer system for the most part. You saw Paul's polls. I have one word for it. It's polarized in Washington right now as to views on health care. And my personal opinion is health care policy should never be political policy. Health care policy should be do what's best for the patient, regardless. The other thing is, will it stifle innovation? You heard Dr. Convery say Medicare, for the most part, and the American Hospital Association did put this out, covers about 87%. Most hospitals lose money on Medicare. Most physicians will tell you 50% for the most part don't take Medicare. It's not because doctors don't do a great job. It's if you look at the fee schedule and what they get paid, it is something that we need to think through. As a result, a lot of innovation, a lot of things that happen that are funded in healthcare, the latest technology, the latest updated plant operations to deliver the best care could be stifled. And it could limit access to providers. By that I mean, what would happen to the 50% of physicians that currently take Medicare if we went to a Medicare for all and they didn't at least have some other payers that would influence their practices? So it's something we need to look at. You know, most hospitals, if they break even on Medicare, they're lucky. And you may go, well, is that a big deal? Most hospitals, Medicare and Medicaid and government programs, represent anywhere from 50 to 60% of their book of business. And that's why there's cost shifting, where the cost is shifted to the commercial payers, which falls right in line with what Dr. Convery was saying when you look at the percent. So let's look at Washington. And how is Washington going to impact Medicare for all? You hear a lot about Democrats. I will tell you, though, the Speaker Pelosi is very much against even bringing up Medicare for all to be voted on. And the reason is, if you look at the Democratic majority in the House, which they got from the last election, there were about 24 or 25 what we refer to as blue dog Democrats. These are Democrats that won in traditional Republican districts. You saw the survey that Dr. Convery put up. Most Republicans don't favor Medicare for all. She does not want a vote on Medicare for all where she throws these blue dog Democrats in their first year in Congress into a situation where they have to go on the record, yay or nay, Medicare for all. That's why nothing's going to happen, in my opinion, until after 2020, after the election. There's not going to be any vote on Medicare for all until after the presidential election, if then. The other thing, and the American Hospital Association is one of these, so I'm not pointing fingers. There are 1,800 organizations in Washington that lobby on health care. Now, what's wrong with that picture? I mean, that is why you get so many different factions from different angles. Everything seems to be polarized when it comes to healthcare solutions. And even after 2020, I don't think there will be a vote on Medicare for all, and I'll tell you why. I don't think there are going to be enough Democratic senators that win where the Democrats would take control of the Senate and have 60 Democratic senators. Why is that important? You can filibuster, and you can't override a filibuster unless you have 60 votes. So Medicare for all is a lot of talking points, and it is being talked about in the presidential election. I really don't see a vote on it anytime soon, potentially even after the 2020 election. So what is really the health care law that is currently in effect? It's called the Affordable Care Act, and it currently is the law of the land, not Medicare for all. Dr. Fleming and Dr. Convery covered what's big in the upcoming election. No question about it, health care is front and center. Healthcare is the topic to be discussed, and that's the order in which the priorities related to the issues come into play. Immigration ties into healthcare, but as you can see, the economy does as well, and so on and so forth. So this is going to continue to be a very hot topic and one that we're going to talk about. You've heard about the cost. There's no question about it. Costs are out of control. Providers need to take blame for that. I think insurance companies take blame. All of us are an integral part of this. But I got to tell you, healthcare is very complex. And one of the things also that we tend to forget is the responsibility of the patient. Dallas County, 30% of the children live in poverty. Dallas County, 38% of children are obese. Probably most of them sometime in their lifetime, unless they can change their habits, will develop type 2 diabetes. A lot of that is certainly not their problems. They may live in areas where they don't have good grocery stores. They don't have healthy food. They live in poverty. But there are many parts of Dallas County where people do have access to good food, do have access to exercise, and yet we are a very unhealthy population. Dr. Fleming did an excellent job of showing the cost of health care in other countries versus the U.S., and his numbers are right on. But here's the other thing. Of the 18 industrialized nations that were looked at 3 years ago by the Commonwealth Fund, we ranked dead last in the health of our society. You can talk to a lot of physicians. They're treating people that are baby boomers going on to Medicare, where maybe 20 years ago they had 1 or 2 chronic illnesses. Now they're having multiple chronic illnesses. We have got to strive to do our part also to live healthier lifestyles. If you look also in some of the other countries, they put more into social programs. Dr. Fleming had a great example where roughly 18 to 19% of the GDP is healthcare costs, no question about it. We put about 9 to 10% in social programs. Other countries, if you look at France, Sweden, and Switzerland, they put a lot more into housing, transportation, etc., which really affects the social determinants of health. So we're all in this together. And Medicare for all is something to consider in having coverage, but we also have got to try to improve the state of our health. You know, drug costs have been touched on, pharmaceutical costs. It's all part of it. Providers, pharmaceutical companies, all of us are part of the problem and need to be part of the solution. Many of our rural hospitals are closing. We've had 19 rural hospitals in Texas close in the last 3 years. And we really have got to focus on that because people need those hospitals in their community. let's look at Texas overall. You hear a lot about uninsured. We've got 5 million uninsured in Texas. 5 million. That's a lot of people. If we had expanded Medicaid under the current law, the Affordable Care Act, 1.5 million people would immediately get coverage. We also have a Medicaid 1115 waiver that's nearing its end. There are a lot of projects in that Medicaid waiver that are going to go away unless we can work collaboratively together for solutions. And then the public charge. I mentioned about immigration. The public charge, for those of you that don't know what that is, it's kind of a scorecard on people that are here legally, people that have their green card. But you look at the public charge on what governmental assistance are they getting. Because there have been some executive orders recently affecting that, many people are not signing their children up on CHIP. Many people are not signing up for government benefits because it'll count against them in the public charge. That also is going to impact health care and where people receive treatment. So what are some alternative thoughts on Medicare for All from a hospital point of view? Let's continue implementing appropriately the Affordable Care Act, and let's expand Medicaid in the 14 states where they haven't. We need to look at the people that fall in a gap between being eligible for Medicaid and being eligible for the public health exchange. And maybe there's a subsidy that we can do. We've got to strengthen the marketplace. We've got to do robust enrollment efforts. You know, the budget for marketing, the budget for enrollment has been really cut tremendously in the last 2 years. And as a result, many people eligible for current benefits aren't signing up. And as I've said earlier, public health policy, in our opinion, should not be political. So what do people really want when you hear the cry for help? We need to be transparent. Hospitals need to be transparent. Physicians need to be transparent. We need to strive to educate people on what the true cost is. We need to look at coverage. Coverage is one thing, access is another. We need to strive to give coverage and access. And ultimately what people want is what Dr. Fleming said. What is it going to cost me when I look at my premiums and when I look at my out-of-pocket cost? And if we can all work together and strive to come up with a solution that will answer these questions, it might be a good alternative to Medicare for All, and in the long run, it may be cheaper. I want to thank you. It's been a real privilege, and look forward to the questions.
Okay, can you all hear me? Good, thank you. Well, this is a heavy way to start a Monday morning. Is everybody feeling good about their week? So my name is David Toomey, and I'm a roamer, so I'm going to walk around. I like audience participation, so I'm going to ask some questions, show of hands, individuals kind of weighing in. I've been in healthcare for about 30 years, 33 years, and guess what we keep talking about? Same damn thing. Why are we not solving the problem? And this is a meaty, meaty topic, right? This is complex. We're talking about healthcare coverage, right? Look right, look left. Do you want coverage for him when he gets sick? Do you want coverage for him when he gets sick? Who does not want coverage for people in their neighborhood or in their community when they're sick? Show of hands, anybody that want coverage? Great. Everybody wants health care for all. No doubt. Now, the big question. How much do you want to pay more for him to have health care for all at any time, regardless of his lifestyle, regardless of what he does? Answer the question. Thank you. This is hard. How much do you want to pay? So now my background, I ran insurance companies for 25 years. So I represent the healthcare industry. I wanted to do the right thing. I didn't want to make too much money. I just wanted to earn conscious capitalism, bring a fair price, be able to afford to make things for my family. And I try to develop innovative solutions. And I've watched the healthcare delivery system, the hospitals, et cetera, fascinated about all the innovation. And I scratch my head saying, why is this not adopted by everybody when it's a great solution? Why is it not adopted by every health system in America when you have a great solution? Any idea why it would not be? Same with me. I'm the youngest of 7 kids. I grew up in Alabama. So mother, why are we going to do this? How much is it going to cost? Because I was the youngest, right? When the chicken platter came around on Sunday, I would reach for the chicken breast. Of course, my brothers would beat me up, and I'd get the back. Now, that's how I grew up. I had to make choices. And those hard choices, right? So a big day occurred in the Tootney household last week. My oldest got a job. So she was all excited because she said, Dad, I got this great offer. I said, fantastic. Now here's your salary. What else do you need to look at? I said, I don't know. Your benefits. What are your benefits? So she starts doing the math, and she was like, wow, I need to ask for more money. I'm like, that's your choice, right? Because this is expensive. Benefits are expensive, right? And as an employer, we think about all this stuff as how much do you want to pay? And we've talked about this, so come and clean up. You're going to hear some repetitive slides and messaging, right? We know healthcare is really, really expensive, but our life expectancy is terrible. So we're paying a lot of money for healthcare, and we're dying early. Does that make sense? Anyone? No. We're paying more for healthcare, and we're not living longer. Why is this? Why are we doing this? So I'm going to take it down a level, because when I hear trillions or billions, I don't understand what that means. I'm not that smart. So I got to bring it down to healthcare costs we've been talking about for a family. I'm the employer. For every person I employ in their family, I'm spending over $20,000. And that's going up 5% a year. Ain't that great? $20,000, going up 5% a year. On the flip side, guess what that means? Sorry about your salary increases. But you're paying more for health care. I can't give you much of a salary increase because it's costing me more money for health care. Okay, that's reality. Inflation's going up 2% a year, sorry. But you're barely affording to live. Welcome, students. And so you think about the payroll deduction. So now I'm going to have you pay more money because it's costing me over $20,000. My salary's only going up a certain amount of money. Inflation's going up a little bit. And now your payroll deductions are going up too. Anybody feeling good? And the cost of family coverage, because I got kids, gone up 25%. So my salaries have not gone up. My healthcare costs have gone up. And I'm getting more taken out of my paycheck, and I'm getting more taken out of my cost if I use the healthcare system. As we've talked about, $1,600. You're the employer. Health insurance company provides you healthcare coverage. This is a question for the audience. Who ultimately pays the bills? Thank you. Now, who funds it at $20,000? Was it me and my insurance company role? No, it's the employers. So your company is forced with decisions. Because we've been talking about healthcare for about 30, 40 years. Medicare for all, the tipping point, I'm tired of the tip, right? Let's just solve the problem because it's going up. And we've talked about this, 60 million people covered in Medicare, spending $741 million. The hospital insurance fund is spending $1 billion more than the revenue that comes in. So you got a bank account, you're spending $1 more than you take in, and you keep spending that kind of money? Thank you, no. Part A cost, that's the hospital fund, going up about 3.7%. Part B cost, 6.6%. The trust fund is out of money. We're bankrupt 2026. Now last year, 2017 report said that we were going to be out of money in 2029. Oops. We're 3 years short. We're going to be out in 2026. And guess what it says? Every time the CMS Trust Fund report comes out, Act with a sense of urgency, Congress and executive branch. Every time they produce this report, we're out of money. Okay? Reality is, we can't wait for the government to fix it. So my objective is to make sure you understand this is not a government-driven solution. I would love for everybody to have health care, but who pays the bills? You and the employers. Their driven solutions must come to fruition. So we know health costs are going up. We've been talking about that forever, right? Then we got healthcare waste, 30% waste. 30% waste. So if you ran your household and you had 30% waste in your bank account every month, every week, would you keep wasting money? Why do you do that in healthcare? 30% waste. Now what does that mean, 30% waste, and I'll talk about that as well. Back surgeries, 15-fold increase in back surgeries. What is almost 20% of the GDP? Healthcare. It is a big business. Now, how do we recognize the great, high-quality physicians and hospitals that Steve represents? How do we help them escalate and set the bar? How do we find the ethically, moral-driven, high-conscious couples, surgeons that are not doing it unnecessarily, but doing it quality-based healthcare? How do we reward them and find them and help connect patients? Because our reality, from an economic viability, our healthcare costs are higher than market average. So if you're a company and you're thinking about where do I relocate my business or where do I stay, it's a great place to live in Dallas. Very affordable. But we have the highest uninsured rate in the country. We're double the national average. So what does that mean? Guess who pays the bills? You do. So Monday morning, I want you mad as hell so you don't take it anymore. I want to teach you about why this is so expensive. What can we do about it? And this is a wide variation. This was a study done using Blue Cross data, insurance company data. And so you can see wide variation amongst physician groups on low back pay. It ranged from a total allowed procedure from $5,700, $5,200, up to $14,000. Wide variation. If Toyota made a car that had this much variation, would Toyota be in business? No. If Ford or GM or anybody else had this much variation, why would we keep buying that car? Right? Now, I came from Seattle before moving to Texas about 15 years ago. And I'm the why guy. Why is it so expensive? And so I got some employers together, and we started talking about healthcare. And Starbucks was a client. Starbucks said, we have wide variation in back pay cost, right? Same story. Because what's Starbucks' number one healthcare issue? Back pain. Why? They have baristas. They stand on their feet all day. Their back starts hurting. So we went to the healthcare system and said, well, walk through your process of care and the way you treat somebody with back pain. Well, you schedule an appointment, you wait, then you get another follow-up with a specialist. They want to do an MRI. That makes sense, right? And then you come back and get the review of your MRI. Then you get to consult with another specialist to see a physiatrist, and then you start PT. Now, Starbucks said, this is crazy, right? How much % of the time do you end up in physical therapy? 83%. So I'm going through all this to get to 83% of the time getting to physical therapy. Yeah, that's the way our process of care is built. Well, Starbucks said, well, this doesn't work for me. Now, guess what the CFO said of this health system? Any idea what the CFO said from this process of care? I make money every step of the way. It's 20% of our GDP. This is a big business, right? And they never thought about it from the customer's perspective of the ultimate purchaser, the ultimate payer. They thought me, the Aetna guy, was going to pay everything, right? The reality is, Starbucks paid the bills. Your employers paid the bills. And so if your healthcare costs go up, your salaries don't go up. They're not going to cover inflation. They're going to cost shift to you because it's expensive. And so from that, Starbucks says, well, I don't want to buy this service from you. I don't want to buy this service from you. Now, they didn't like hearing that from Starbucks because it was a major employer in Seattle, Washington. So if I come to you to say I'm not going to buy your service because I don't like your process of care, what are your options? Go somewhere else. Or you could say, holy crap, I can't lose Starbucks and other people because if Starbucks fires me, guess what Costco may do? Well, I'm going to follow the leader. If Starbucks said this is no good, Costco will say, well, I don't want to buy this either. I'm going to go somewhere else. This system was smart enough to say, I got to change. And so, guess what they did? Same day appointments. Come in, we'll get you into a spine clinic, we'll get you to see a physiatrist, and then we'll get you on average PT visits to 2.8 visits per patient, right? I'm going to treat your back pain. Don't go get an injection, don't go get a shot, don't go get surgery, don't go do any of that. I'm going to get you same day appointments. Now the CFO of this system was panicked because they were making a lot of money on this one. And to move to this, removal of non-value-added waste. Six Sigma in healthcare. How do we bring a Six Sigma mentality to healthcare? Now in 2006, a system up in Pennsylvania called the Geisinger Health System. Have you heard of Geisinger? Right? So they introduced the proven care model. 60 steps that have to be done before you have your surgical procedure. And guess what they did? They went to employers around the country say, for your procedure, send it to me. We have a Six Sigma approach, and we're going to do all the surgical procedures that way. That seems like a practical approach to healthcare, right? We're going to just make sure you get the right level of care at the right time. If you don't do one of those steps, we're going to cancel your surgery until we close that step. And I'm going to guarantee the price. And if you have any complications, come back in, and I'll pay the bill. Because it's Six Sigma. That was 2006. Any idea how many systems around the country are embracing this model? Any idea? Not many. Not saying there's not great quality healthcare system in DFW. We have great healthcare in DFW. Great hospital systems. We've got to elevate the game of those systems to create competition. Because when flat screen TVs came out, $2,000 to $3,000. You can get a Costco or Walmart or wherever and buy it for $500, $600 now. Even better quality. But that's driven by the individual saying, I ain't paying for that. I want to get high quality, high value health care. Ask why. Why is this so expensive? Now, audience participation. What's one of the largest employers in Dallas-Fort Worth? One of the largest employers in Dallas-Fort Worth. Walmart. What does Walmart do? They sell goods. But they also, guess what Walmart does? They employ 1.6 million associates. 1.6 million. That's a lot of people. That's a major employer around the country. Major buying power that control that many patients. And Walmart has to be competitive with Amazon. Amazon's now gotten in the business of healthcare. They formed a relationship with Berkshire Hathaway, a big bank. It's now called the ABJ initiative, where they're going to say, I'm going to get healthcare under my control. Why? Because I can't afford the status quo. I ain't waiting for the government to fix this stuff. I've got to fix it because it's affecting my bottom line. It's affecting my margins, how much I pay people, and I've got to deal with this stuff because I want to buy that. And guess what Walmart did about 3 to 5 years ago? If you want to have a back procedure, a cardiac procedure, or cancer, you can go wherever you want to. But if you want to go over here, I'm going to cover it at 100%. You want to go there, I'm going to cover it at 50%. Now, why do they do that? Why do you think they did that? Why do they say some places you're covered at 100%, some places you're covered at 50%? No. Higher quality health care. Because I don't want you getting this. I want you, as my associates, to get this. And they knew, as a general consumer, are you equipped to figure out who's doing that versus this? You need help. So I'm going to tell you where to go, because I've done this research, to go to this facility over here, and if you go there, it's free of charge. Now, mind you, you gotta travel. So if you live in Dallas, you may not get your procedure done in Dallas. You may go to Springfield, Missouri, or you could go to Cleveland Clinic, or you could go to these renowned places. And when they did that, guess what happened? Those back procedures, that back surgery, that cardiac procedure, the cancer, a 30 to 35% improvement in quality of care. Unnecessary back surgeries were cut out. The right diagnosis of cancer was determined because they got their people, their associates, their most important asset into here. Because they know their associates need help. They don't know where to go. They're lost. You drive the freeway, how many billboards? Right? Advertising. You're overwhelmed, but I want good quality health care. And so Walmart is now in the healthcare business. They're taking things under control. Follow the leader, employers, because what they're now going to do is, if you're doing this, if you're doing a really great job, I'm going to help get you more patients. And if you want to lose, because you can say no, that's fine. But then you're either going to change or go out of business. Because I can't afford to keep doing business the same old way. So now Walmart's done that for various surgical procedures. Think of the Part A insurance fund. I'm going to channel people into the high quality providers. And now they're moving into primary care physicians. I'm going to find the Part B, the really good doctors that are part of a high quality Six Sigma approach to healthcare. Free market competition. We cannot wait for the government to fix healthcare. We've been talking about it forever. And it's the same old, same old. So I appreciate the hyperbole. The reality is we can't afford this. We got to do something different. So thank you for your participation. Look forward to your questions.
Thank you, gentlemen. Have we stimulated you a little bit today? I would certainly hope so. Our ambassadors here have mobile microphones. So if you have questions for our panel, raise your hand. We've got one over here. And bring up your questions, ladies and gentlemen.
Good morning. Thank you. Excellent presentations, all. Thank you very much. You've all mentioned that healthcare costs in America are a real problem. This is absolutely true. I agree. I'm in the specialty pharmaceutical industry, so I'm very aware of the excessive costs of healthcare in this country. You all mentioned that in America we pay more for healthcare than most of the other industrialized nations, and yet not one of you mentioned anything about the fact that the U.S. taxpayer is subsidizing lower costs around the world. In other words, a pharmaceutical company will charge a third to a half less in a country like Switzerland for a very expensive pharmaceutical product and turn around and raise the price in America to make up for that difference. The administration has proposed to level the playing field, to make pharmaceutical manufacturers accountable for the fact that these drug prices are much lower around the world in other industrialized nations. We should pay no more for those pharmaceuticals, especially because most of them were developed here in innovation and research institutions here in America, and yet those countries around the world are paying a much lower price for those same pharmaceuticals. So that's one way to lower healthcare costs. Another is transparency. Talked about Walmart. Walmart Health just opened up a healthcare center, I believe in Dallas, Georgia.
Dallas, Georgia, yes.
They display their prices on a menu when you walk in. It's transparent. I've got a 29-year-old daughter.
Excuse me, but is there a question there? Not.
Yeah.
We have others, and please,
Yeah.
you know, your points are good, but not editorialized. Do you have questions for the panelists, please?
Yeah. What can we do to make those prices more transparent for procedures why aren't hospitals, for example, making those prices transparent so everyone can see what they're up against before going into a hospital for a procedure?
Steve?
Sure, I'll be glad to address that. Hospitals support transparency. Unfortunately, the system we have, and it's kind of what David Toomey said, it's been around for years, is we had a charge master. And I'm so old, I've been in healthcare 45 years. I'll be honest with you, it used to go up like 5% every year. So all of a sudden, the rack rate, for lack of a better term, the charge for an aspirin is $100, which is absurd, or for a procedure. What we really need, and CMS, and I know we've got people here from the federal government, some of my good friends, CMS proposed that we post the charge master on a website, and we're doing that, but that doesn't really help. That doesn't help the average consumer at all. What we need to do is bring all the stakeholders together and come up with a way to be transparent on prices and not violate some federal laws about antitrust. So the other thing we need to take into place, and I totally agree with you, if you're going to do a procedure and it's strictly just a procedure, you could compare the price. The other thing, though, you have to be careful on is the acuity level of the patient. And I'm not a clinician, but I've talked to a lot of physicians, and someone who is obese, et cetera, and they're diabetic, it's probably going to be more cost than someone else. But we need to do a better job of transparency, but we still have a long way to go.
Dave?
So I like to bring it down to personal levels, and I'll share some personal information. So recently I had a bladder stone. For the men in the audience, it's very painful. For the females, I'm assuming it's painful for y'all as well, but it's really painful. So I went to the emergency room. $20,000. So before I had things to rule out, they're like, well, we may need to do a lower scan. It's like, okay, how much is it going to cost me? That'll be $730. Like, really? Okay, $730, I'll pay $730 to rule out cancer and everything else because I'm healthy. The bill, $4,300. I was like, wait a minute, you told me $730 and now I'm getting billed $4,300. Could you please clarify why you're not honoring what your representative told me? Oh, well, they didn't know. And I was like, well, I wouldn't have the procedure done for $4,300 because I'm a low-risk guy. I'm really healthy, knock on wood. $20,000. I was like, I'm not going to Africa for 2 weeks with my family. I just want to be able to go to the restroom, right? And so they fixed me, unclogged, $20,000. And I got billed at the highest level. There's 5 levels of emergency room visits, 1 to 5. My ER visit was a level 4. I left without any diagnosis. Everything came back clear. And I was like, how is this one of the most complicated procedures of the ER visits? 1 to 4. Why is this a 4? Help me understand my situation. Because I just sat in the exam room and I just worked because I felt fine. That's how we code. And then I had to come back and it was like, oh, you're a level 5 now. I'm like, seriously? I'm questioning the bills. I appreciate transparency. I appreciate charge master. I just want to know how much it costs me. Why? Because I'm the youngest of 7 kids. I need to know how much it costs because I'm not paying for unnecessary waste. We have to demand pricing before we have the services done. And find really good physicians and health systems that will purport that. Because there's a lot of great ones that do. Reward them with good behavior. Help them get more patient volume versus not rewarding those that won't do that procedure. And let me know the pricing up front.
So I agree. Transparency is the market-based buzz phrase of this decade in healthcare, and you're probably going to hear it for another 5 years. In the last 30 years, we've been trying to solve the healthcare cost dilemma using the American free market system. We've gone through DRGs, we've gone through managed care, We've gone through quality initiatives, we've gone through lean, and the latest market solution is transparency, and I'm all for transparency. And also I'm all for the free market system. I've lived in the free market system my entire life, and as we say here in Texas, it's been mighty good to me. So I have no problem with the free market system. However, there is a place in all the Medicare for All proposals, or the options, and this could be done without a Medicare for All policy, is some type of price regulation or negotiation on a government or a state level. Now, that sounds very anti-free market, but you've got to appreciate the fact that the basis of a free market economy is that each individual actor is incentivized to raise as much profit as they can. That's what the free market does. And then it's offset by the individual buyers making a decision, do I want to buy that or not, or do I want to go someplace else and find a better price? And that keeps the world in balance. We don't have that in healthcare. And there's precedents for the government at either the state or federal level to step in and to regulate that. Since 1984, the Federal Trade Commission has had guidelines and rules around the funeral industry practices. It's part of the federal regulations that control what funeral homes can charge at times of a death, because they feel that the bereaved are at a disadvantage and have asymmetric information in buying funeral prices. So they have guidelines to keep this balanced, and it's worked, and there hasn't been a lot of complaints. Most states have laws prohibiting price gouging in times of distress, floods, fires, tornadoes, hurricanes. And you hear that all the time, that they almost all, I think about 15 don't, but most states have laws saying you can't raise prices for necessities above 10%, 15%. I would argue that people in healthcare have asymmetrical knowledge and are in distress. And we take care of that in healthcare because Medicare sets prices for hospitals and physicians, but they don't for pharmaceuticals. The Congress exempted pharmaceutical industry from, and so they can set prices wherever they want to. Medicaid has a maximum allowable cost provision for drugs. And so Medicaid controls pharmaceuticals, but Medicare doesn't. And then on the commercial side, the business solution is commercial insurers are to negotiate with health systems and hospitals to control the prices. That's where the field's supposed to be leveled, but we know from the RAND Health Price Transparency Study that hospitals are paid by commercial insurers 250% to 1,000%. So that system hasn't worked to date. And we know on the pharmacy side that pharmacy benefit managers are supposed to be the middleman to control pharmacy prices. But we know that that hasn't worked to date. The cost of insulin has gone from $74 a vial to $268 a vial over the last 10 years. So I think there is an argument and a place in there for some kind of middleman to step in, and maybe that should be the government, because insurance and the market has tried to step in, but it hasn't regulated that. That, along with transparency, may get to that. Now, transparency is very complex, and it's hard to give prices, but I encourage you to look at the Oklahoma Surgical Institute.
Surgery Center of Oklahoma.
Surgery Center of Oklahoma, thank you. And go on their website, and I have no vested interest. I don't own part of it. My wife doesn't own part of it. My children don't own part of it. My son-in-law doesn't own part of it. It's an interesting website, and you can go in there and put in what procedure you want, and the price comes up. If they can do it, it's not undoable. It's not because we're not smart enough. I think we're smart enough to not make things transparent.
They've also started another organization called the Free Medical Market Association,
Yeah, thank you.
Questions?
Jim Walton, I'm with Genesis. I was curious how you would respond to, I think, Paul's comment about this idea that we need a regulated pricing environment, and you have more of a free market based on the employer basis. And so one of the reactions to the market with regard to employer innovation, which controls a pretty big chunk of the spending, not all of the spending, because there's a lot that's in the government sector, is consolidations of the healthcare systems. Consolidation of the healthcare systems is really driving price, and holding price up within because of the cost transfers that Steve was talking about. So can you get more precise about this dualistic issue, which we've got the employers doing innovation to kind of control price and waste, both utilization side and the price side? I think I understood your utilization side control, but I was wondering about what you think about with price, particularly in light of the government needing to kind of start regulating the price for the hospitals a little bit tighter, which Paul's talking about, which impacts the hospital's margins, which they have to transfer over to the employer. And so the only way they can do that is by growing and consolidating and basically reducing choice. So now all of a sudden we only have 2 options or 3 options in the state of Texas because everybody's consolidated, if you will, into these massive monolithic systems that have now set price. Can you respond to that? And then Steve, can you kind of respond to him?
Yeah, I mean, every other industry has gone through consolidation, right? You look at the airline industry, it's consolidated. And then all of a sudden, somebody new crops up, Spirit or Frontier and Sun Country. There's new innovation that comes in to say, I'm gonna compete, right? So there is massive consolidation that's going on in the healthcare system. Right? When I was at an insurance company in the local marketplace, the local hospital got built. And I went to the major employers in that area and it's like, did you know your healthcare costs just went up 34%? I'm like, why? It's like, the name on the hospital system just changed. They got acquired. It's no longer the local system. And I'm sure you've all seen the New Yorker report from Atul Gawande that talked about Medicare and the wide variation from McAllen, Texas being the highest Medicare market in the country versus others. Right? Pricing alone is not enough. I can pay you per unit. I'm going to lower how much the office visit is or the surgical procedure, but as an entrepreneur, I can just do more stuff. And so it's the volume. And working with employers around the country, Walmart's a client, right? They just said, you can charge me more for the per unit as long as you get the 30% waste out and you don't do unnecessary back procedures. It's called value. Every employer in America that I've worked with will pay for value. But there has to be a relationship with the supplier, physicians and hospitals, that want to work with the buyer, the purchaser, in a value relationship. And then assess what do you do to cut out the unnecessary waste. And so that's a different conversation. That is the opportunity to really get the 30% plus waste out of the system. That's what we got to get to. So my sister worked at an academic institution. And every time there was a hurricane in the South, guess what happened? She would clear her floor for the incoming patients. I was like, how in the heck does that happen? How do you all of a sudden clear your floor? Like, well, they could go home a couple of days early if they needed to. It's a business. And so we've got to get into that. I'm going to get the unnecessary patients out of the facility in order to afford to bring in more patients at that appropriate financial motivation from a healthcare supplier. That's just my take.
I know you asked me to respond. I can't disagree with what David is saying. I do think, Jim, there are going to be more consolidations of hospitals and physician groups. I do think if you look at providers from a physician point of view and a hospital point of view, to have set charges could be a slippery slope from their point of view. I do think, though, that as we look at consolidation, and we all know as you get larger, you have more purchasing power when you negotiate with Blue Cross or Cigna or Aetna. How do we strike the balance that we need? I think they're somewhere in between, but I'm not sure what the right answer is. But the free market system makes sense. Paul makes good points on what he said as well. And maybe we need to all sit down and see, is there any way we can get in the middle? But it's a very good question.
Okay, it's 9 o'clock, quitting time, folks. Let's give our panel a nice round.